All right. Hi, everybody. I'm Andrea King with Pub Health AI Collaborative Network, and today we're talking with Kerry Weinberg of PhenoML, and she's going to tell us about her experience using FHIR and AI and the opportunities and challenges therein. So we're going to go through a lot of practical talk, and you'll hear from the challenges people face every day on this topic. Go ahead, Kerry.
Awesome. Yeah, thanks for having me. I'm really excited to be chatting with you all. This is a take on a talk I've given previously for the HL7 community. We partner very closely with HL7 as part of various initiatives in the AI space, and we're the only company that HL7 has sponsored to teach folks how to build agents. So we hold those courses. I'll give a brief summary on my personal background for context, and then my talk's going to be, focused on pragmatically what we see, mostly from the private sector, some examples from the public sector, in terms of folks building at the intersection of HL7 FHIR, Fast Healthcare Interoperability Resources Data Standard for Interop, and AI. I started my career in medical devices, so I worked at Beckman Coulter. Started as a systems engineer on instruments that sorted cells, primarily for researchers. Then later went back to grad school. My background's in biological engineering. I built out Amgen's AI team. So my team there did ML-based real-world evidence research. During Operation Warp Speed, we worked with a number of folks in the public sector as part of predicting pandemic spread to inform where we were focusing our clinical trials globally. After that, I was the VP data at League. League's a healthcare software company, mostly sold software to the payer space, mostly private payers in the United States, some in Canada. We powered one of the largest FHIR servers in North America for patients across the US and Canada. And I'm the founder and CEO of PhenoML. We're a developer platform for healthcare data and AI. So we make a bunch of different APIs, different software systems to help folks build solutions, power interoperability with data, deterministically extract medical codes from unstructured data. And yeah, really excited to be with you all today, and hopefully can demystify some of the noise you hear. I think in the private sector in particular, there's a lot of noise, and it doesn't match practically what we're seeing in terms of what people are using and the real challenges that they face. If you take away nothing from my talk today, it's that most of the problems folks have today are things that we've always had. So what we see are companies in particular not struggling with technology. They're struggling with empathy for their end user and building practical solutions that actually help patients, providers, and researchers. So some things never change. That's one of the most practical takeaways. So I like to describe building in healthcare today, whether you're working with healthcare data from an informatics perspective, or you're building agents for doctors, you're a time traveler. You're both working with data from the past with faxes, as well as MCP servers that are now available with EHRs that we never had before. And so I think there's a lot that we could take away both from our history in the space at healthcare and machine learning, as well as what we're seeing today. So let's take a trip down memory lane to 2022. Actually, in preparation for this talk, I rewatched a talk I gave at the MLConf, it's a machine learning conference in New York in 2022. And some of what I said we've solved as an industry, sort of, and some of it we truly have not made any progress. So I always think that's kind of funny to go back in time with some of these, even papers, some of these things don't change. So 2022, we finally started getting some interoperability. We had patient access APIs, essentially the government requiring if you're a system that wants to treat patients that are on Medicare or Medicaid, you need to have your EHR be conformant to ONC requirements, and you need to make the data available for patients to get via patient access APIs. And this was a really big deal, as I'm sure many of you appreciate, and you have far more experience in that space than I do. But it was a huge deal, especially for those in the private sector, because we never had that ability. If you were building different applications and you wanted to enable a patient to retrieve their own data, or even patients ourselves, if you're like ever had an MRI and you receive it on a CD, we were like, it'll all get solved with patient access APIs. We're still dealing with some of that. And so we didn't have ChatGPT yet, so we were still talking about building machine learning models. We were figuring out how do we even represent machine learning in the FHIR space. So in the FHIR standard, we have lots of different ways to represent data. We spend a lot of time worrying about and thinking about how to best represent and reflect different systems. And FHIR is, I think, a really impressive amalgamation of so many smart people in the industry, because we need to have a standardized mechanism of reflecting healthcare as it's practiced across a multitude of different specialties, as it's practiced across device manufacturers, biopharma manufacturers, providers, payers, researchers. And so in 2022, we were trying to figure out, how do we reflect machine learning outputs? Do we represent them as a device? How do we best reflect them from an interoperability perspective? And at the time, our thesis was that if we just had everyone structure things, we're good. Like, that'll solve our problems. So now we're today, and a lot has changed, but many things haven't. Some things that have changed is MCP, so Model Context Protocol, made a lot of like an absurd amount of noise last year. And like, even my dad knew what MCP is. My dad's 80. He's not from the healthcare industry. He's a retired commercial real estate appraiser. But MCP was everywhere. It's a Model Context Protocol. It's basically helping LLMs make API calls. That's it. It's not that complicated. But people got really excited about it. Agentic engineering. We've got agents that are reading the web page to figure out what you're clicking, because those EHRs don't have to expose APIs. We've had folks building all of these different systems, and there was a perspective that was quite loud in the private sector, particularly in the last year to 2 years, which was, we don't need structure anymore. We'll just throw all of the data and all of the faxes into the LLMs, and we'll just make money. That's it. That's all we have to do. If you take away another sort of tidbit from my talk, I just don't believe that that's true. And it's not for lack of the technology itself. I think it's really impactful and truly makes a huge difference, but there's no substitute for good old-fashioned math and statistics, and truly understanding what's going on in a complex system. And so, and in terms of actually making an impact, I think that AI and agents can enable us to move at a speed in terms of building those types of models or doing those kinds of statistics that we were never able to do previously. But it doesn't mean we should all just turn off our brains and just let Claude tell us a causal relationship. We have fantastic tools to be able to do that. And I don't think there's any substitute for having data structure. And so where are we at in 2026? So the first one is interrupt solved, right? Like, we'll just throw it all in the LLMs. We don't need any data structure. It's fine. All the agents will talk to each other, and we don't have to standardize anything. Obviously, I have thoughts on that. The second thing I'll talk about in more detail is determinism and explainability. So as an industry, particularly in the private sector, have adopted AI in an insane amount, like an insane rate, the bottleneck has shifted from output to trustworthiness and reliability. And so now I would argue determinism and explainability are valued so much more than they used to. Back in 2018, we were talking about explainable AI, and it made a huge impact in terms of particularly clinicians interpreting outputs. That's almost more important now. And I'll give an example in our work with a customer about how powering determinism and explainability can make a big impact, leveraging AI to power that to ultimately benefit precision medicine. And then the last theme is at the intersection of LLMs, FHIR specifically, and conformance, but I would argue that this also applies to a lot of epidemiological best practices. I don't know if you're experiencing this in the public sector, but at least in the private sector, it's shocking to me how much in 2026 that I'd be arguing with other people's thoughts in terms of how to do different types of analyses and how to represent data accurately in FHIR. We even had one of the leaders at the National Library of Medicine attend a recent HL7 talk we gave. And it was interesting to hear about UMLS, which is, I think, one of the most incredible data repositories that's available to us, which is, represents years of experience from across the sector. Folks would rather, ask an LLM for an answer that we already actually have a lot of really citable sources for that are structured in UMLS. I think the trick there is then making UMLS more accessible to more people to make an impact. And so, okay, so on my first theme, interop is solved, right? Like, we're good. What is interesting here is a couple pieces. So one is that, okay, well, we have all these FHIR APIs. We're now required to expose them. The payers have to expose APIs for prior authorization. But fundamentally, what gets structured is what folks are incentivized financially or legally to structure. That's my maybe very cynical view of it, but I've worked with millions of healthcare records, global data sets, and what you see consistently is if somebody is not going to get paid or is not going to get in trouble for not recording something, then they won't record it in a more structured way. They will only record it in a structured way that they need to. The reality is, if you are practicing in medicine today, so your job is hard enough to then have to enter information into a GUI that some other engineer designed who doesn't, in many cases, doesn't have that end user in mind. They're going to just put everything in the notes. So I recently went to, just to give you a very practical example, I recently went to a visit at McLean Hospital. It's one of I think it's one of the best behavioral health hospitals in the world. I went with someone very close to me who's a patient there. They were receiving TMS therapy. And I was asked if I could watch the nurse chart, and they said no problem because the patient was fine with me seeing it. So I watched them chart. McLean is part of Mass General Brigham, world leader in healthcare, like arguably. The clinicians using dot phrases, so in EHRs you can just do like dot dot and it'll like auto chart your outputs. And then they were deleting sections and adding their own annotations. And what is fascinating to me is we see this in terms of downstream data that our customers use from HIEs, where most of the really good stuff is in the document references, basically the notes section. And so from a clinical perspective, the clinicians are going to be using, they're going to enter the problem list items if they know that they have to do that for a billing perspective, or if it's going to power some kind of an automated clinical decision support flow. Any kind of use case like that, but they're using the notes as a way to communicate to the next person. So it's not just recording the information for the visit, it's also almost functions as an email. So if you think of it as like a handoff to somebody else when they're going to take over for you, it's not just I'm recording to record it, which I think to the question in the chat about ambient AI, like scribes, the use case for scribes historically was like, I have to chart and I have to do it for documentation purposes. Now what we're hearing is folks are starting to get frustrated with the scribes that they so adored a couple of years ago because now they're spending so much time reviewing the accuracy of the scribes. Because it functions not just as a documentation source, it also functions as communication. And so for example, if I had Granola record all of my interactions and then it just always sent off emails for me automatically, I don't think I would like that. I would have to review the results, but that's actually the functionality. When you think about how data is stored in an EHR, it's functioning as a communication device. And so I think that when we end up using this data downstream as researchers or folks that are building different solutions to help providers handle prior authorization, it's really important to get a sense about like what were the incentives at play for the folks that generated that data, because it's often very different than the folks that are consuming it. And unfortunately, often what happens is we then try to put that burden on the person who's entering the information. We're of the belief that there's better tooling that can help transform that information in a structured way for those users so that they can enter it in the various structured formats that work for them. The second theme I want to talk about is determinism and explainability. I think this is really interesting because a lot of the folks that have built in the agentic space in the past couple of years, they came from a software space. They didn't come from hardware and they didn't come from biology. And in hardware and biology, we're really used to non-determinism. It's expected. Like if you've ever had to grow cells, or if you've ever had to measure something in a lab, if you've, even assembling furniture, if you think about the company, IKEA manufacturing it, and they're going to have variability. Your parts don't always fit perfectly. Software engineers actually never had to worry about this. This wasn't a concern. You could expect your code that you wrote would perform as expected. Of course, in certain cases, some system concerns might start playing a role. But most software engineers didn't have to deal with non-determinism, and they didn't have to deal with with explainability. They could clearly trace through what was happening. And so with LLMs, if you're having an LLM process the data for you or make a decision for you, LLMs are fundamentally non-deterministic, and they often lack true explainability. And so it's really important if you're going to be leveraging these systems, and particularly I believe, having done real world evidence research myself, there's a lot of good work that we have in this space that we can leverage. And if you want your analysis to be repeatable, you likely want to have a standardized or deterministic way to do that. I think AI can really accelerate in developing a lot of those best practices. AI can democratize your ability to apply those best practices. But fundamentally, I would argue that determinism has only become more popular, is what we've seen. And explainability has only become more important. An interesting thing I can share is just a sort of a brief case study with one of our customers. So why is this important? Specifically, why is determinism and explainability important? Like, what does it matter downstream? Well, if you want to be able to apply AI in a manner where then the downstream data that you extract, you want to use it for regulatory purposes. You want to use it for any system where you have to make a decision that you need to be correct. It's quite important to ensure that you have some control, auditability, traceability on how that system is processing your data. One of our customers is a genetic testing company. They have a huge volume of unstructured data, semi-structured information, and it's got really valuable insights on patient phenotypes for rare diseases. Rare diseases present different phenotypes that aren't typically clinically expressed in the standard coding systems. So often there'll be, observations like someone having really high arches, or their facial features are a specific way, or they had a change in when they could express different language skills as a kid. Those aren't per se diagnoses. They're observations about different phenotypic features, and they come up primarily in the unstructured data. And so if you want to be able to mine all of this data for downstream regulatory grade purposes, you need to ensure that the process that's performing on it is going to be explainable. It's going to be characterized in terms of determinism, so that you can rely on it. And so what we actually found was interesting. I like to share this because I think it's really intuitive once I share it, but I think it's often counterintuitive to folks when I first say it, which is that when we optimized for determinism, it actually made it easier for us to improve our system. So let me just take a step back. So taking all of this data that's all unstructured, like old faxes that are, scanned in sideways, or have a big crease down the middle, or are from the 90s, really varying degrees of data quality, and then being able to process all of that data to generate a real-world evidence data set that can be used for downstream research purposes. And so as we were testing and evaluating our platform and our platform's APIs with this customer, one of the things that we found was that by optimizing for determinism, we ended up getting more clarity on consistent error modes where our AI APIs were doing well or weren't doing well. And so it actually, focusing on determinism, helped us highlight edge cases and then systematically remove those edge cases. If we had instead just gone with what many private sector companies do, which is prompt engineering-based systems, it's really difficult to be able to figure out where are you consistently failing or doing well on, because you have so much non-determinism, your error bars are so broad. So it's really hard to tell, like you're typically doing poorly on one area, therefore you have to improve. And so what folks end up doing is they just run a bunch of evals. And so what we found, which I thought was pretty interesting, is when you actually optimize for determinism, it actually helps you get more efficient in improving the accuracy of what you're doing. Another thing that you folks might appreciate is that I find it wild that most of the SWE benchmarks, if you see any of the benchmarks that the AI models have posted about, they'll use benchmarks that are point in time. They're not showing what was the actual distribution, the spread of those benchmarks for multiple runs. They're probably showing the best one. Obviously, we wouldn't do that. Like in the diagnostic space, if you're building a laboratory instrument to measure troponin presence in blood, you wouldn't just do one QC measurement and say, we're good to go, ship it. We would run it in a variety of different conditions to ensure that that result held up. But in the software space, we're not used to doing that. And so I think that that's what we're kind of seeing. Similarly, I think it's really important to leverage actual clinical experts for evals and interpretation. Many folks that are doing evals are using LLMs to do the evaluation for them. But then if you actually put the outputs in front of a clinical geneticist, you'll even find nuances in how they evaluate a result working well or not. And so I think it's really important to actually talk to the people that will be using the outputs downstream. This is something that often folks that are building AI systems neglect is, we're all nerds. We don't want to have to talk to people if we don't want to. I'm an extroverted nerd, so maybe I'm a little different. But typically, nerds don't want to do that. Would rather just build it by themselves, and it's easier to not have to talk to somebody. And so I'm a big believer in talking to the people that will be impacted by your outputs of your research and the outputs of your work, because it tends to yield much better results. Yes, Ronald?
Wait, I think I just heard you say something that's blowing my mind a little. So my background's informatics, and I've way too long now in public health evaluations. And did you just say they use LLMs to evaluate?
Many companies do.
I don't even understand what that means.
They'll use an LLM as a judge. So they'll have Claude look at the outputs of their analysis, or they'll have Claude look at the outputs of their predicted labels.
But LLMs have no theory of mind, no knowledge. It's not actually it's what you're just talking about here. Like you can't actually, yeah, wow. Okay.
Yeah.
Thanks.
Yeah. So this is what we see. And even if you technically correct versus clinically useful, right? So maybe there's something in the evidence in the broader literature that an LLM is picking up that might be correct, but it's not actually practically useful. Nobody would use the result. And so I think that that's something that is, there's a lot of wild stuff that is often happening in the private sector as it applies to, interpretation of these different analyses. And I think this is sort of we're on, the next wave of those, AI journey. The first one was sort of mind-blowing in terms of democratizing a lot of skills that many folks never had access to. And I think that that's really inspiring. I think we're now on the second wave, which is just because you can doesn't mean you should. Just because you can predict an output that has a specific value doesn't mean it's clinically useful. And so, that as another example, CPT coding. If you're going to be doing CPT coding for billing purposes, you could just throw a piece of text and give it to an LLM to give you back a CPT code. But as Laura's pointing out about a rubric, you can have a rubric that defines the lower level pieces that support that CPT code, as has to be at least X number of problems plus prescription management equals a 99214. And so, I guess my main takeaway is there's no substitute for just talking to the people who are going to benefit from your downstream system, because I think that makes a huge impact. I'm not being, per se saying like AI can't do some of these analyses, but I do think it's really important to stress test it against real world people who are actually impacted. And then Jim, to your question about was your foundation in OMOP CDM? So in the API, the process I was describing previously, our APIs here are used to convert the unstructured data to FHIR standard. So we use essentially an ensemble of different ML models for healthcare data extraction to extract different medical codes. And then We do use LLMs, but as different components of our platform to be able to compose that into a structured FHIR output, which we then validate. And then the downstream of that data conforms to the OMOP common data model. That's deterministically done. We don't use LLMs for that component for FHIR to OMOP because of that's already been established quite well. That's another thing that often we find is, if there's a really good deterministic solution for something, it's faster, cheaper, and consistent. We would prefer to use that over an LLM. But often I will find folks who are using LLMs for stuff that can be a very simple rule. Oh yeah, I'll talk about the optimizing for determinism. Yes, so we're a couple things. LLM embeddings can be leveraged in a way that is more deterministic. That's one approach that you can use to improve determinism versus fully generative. The reason why you end up getting that variation in terms of your output is not just due to the fundamental architecture, it's also because of the model providers themselves. You're batching they're batching your requests. So if you're not paying a certain amount of money, Google's going to be putting you with everybody else. And so you might end up with difference in terms of the batch of data that your data was processed with, in which case you might get varying results. Or they're performing some kind of other optimization under the hood that they think works globally, but might end up reducing non-determinism in your specific scenario. So a couple of approaches to manage that can be using open source models where you have full control of them, serving the infrastructure yourself, as well as leveraging different ML-based solutions. We're a big believer in using LLMs to help accelerate our application of ensemble ML models versus using LLMs directly. It depends on the use case you're solving for. But fundamentally, typically what we find is as we remove generative calls from our system, we improve determinism. Or at different stages. It also depends on which stage of the process. So the biggest bang for your buck tends to be at the first layer. So if you have a multi-step process, if you think of it just from a systems engineering point of view, you're going to have the biggest bang for your buck in terms of accuracy, non-determinism, if you make that impact at your first layer. So what we actually have done is we are leveraging OCR models in many cases versus LLMs for the image extraction. The results have been really promising. They're equivalent or beating human abstractors in the tests we've done with our customer. And so we find that actually made a big difference in terms of then identifying downstream opportunities to improve performance overall. Let me talk about another question. Are these post-trained local models or all frontier models? We do a mix. What we also see is a lot of folks are experimenting with doing post-training local models. Many of the open source models are getting almost as good as the frontier ones. And I would argue a lot of the benefit of the frontier models is that they're encapsulated in easy to use APIs. So it just makes it a lot easier to integrate it into your system. I think as more and more, model providers are making it easier to use open source models, that'll get better. But yeah, that's what we do, and that's what we're seeing. The third thing I want to talk about, and I'm very curious on what your perspective is in this space, is the intersection of LLMs now helping folks apply FHIR. I think that's cool. I'm excited about that, but we are having some kind of weird downstream results happening from that. It's really challenging to apply FHIR in a way that's clinically useful and relevant, but also it requires humans and domain expertise in terms of how people actually use this data in practice. Sometimes, outputs that are pedantically the most accurate may not be the most practical. And I would imagine similarly in terms of, analyses that you can do, there's a bunch of best practices that are broadly available. But if you've been working in the space, you kind of know which corners you can cut. You know which assumptions you can make and what will pragmatically make an impact. And so we had an experience recently where someone we were working with was asking Claude to interpret medical codes or FHIR. And this is another case where I just strongly believe you should talk to your end user and what they say is correct versus asking Claude. It's very tempting for a lot of folks to just ask the LLMs directly because it's easier. It's not scary. It doesn't require any social capital. And you can just ask, you get a very nice response. But the challenge is you might feel like you're moving faster, but sometimes you have to go slow to go fast. If you go really fast to produce an output that's not actually going to be useful by anyone who's downstream, then it doesn't kind of matter. And so what's interesting is that we're seeing the cool part, I guess, is that we're seeing more folks have a lot of appetite towards building things in FHIR, which is great. We didn't used to. Often was like, FHIR's too difficult. Too much of a graph structure. I don't want to deal with it. That was what we used to hear. Now we're seeing a lot more developers who are really happy to be standardizing, using medical terminology, but then they're asking Claude how to interpret those medical codes. The challenge here is, again, from a practical perspective, there's differences. For example, in the healthcare space, we know certain codes are more favorable to be used because they're more understandable. They're more favorable for billing. There's a lot of incentives at play. As an example, just one for the ICD-10 coding system. We have codes that are for like, you fell off a skateboard going down the hill on your left side and you fractured your elbow. Like we have extremely specific ICD codes. But practically, most insurers and most providers wouldn't be using the most specific M81 code. They're going to use M81 for a fracture. And so I think it's going to be quite interesting in terms of leveraging data that folks are implementing with LLMs or using LLMs to help them understand conformance, because there's a difference between the code being like semantically the most correct and being one that nobody actually recognizes because they never use it. And so I think that that's quite interesting. And I would say also the gap between implementers and how the data is used is also compressing, in the sense that you can use LLMs at both ends. You can use LLMs to help you implement, and you can use LLMs to help you interpret. And so there's both benefits there. Could be leading to better translation, making things more accessible. Can also be leading to challenges like this, where we're reinventing the wheel. Like UMLS is fantastic. We're like huge fans of UMLS. And it has a lot of these relationships already. And so if you don't want to have to spend and set up a bunch of money to process, have Claude or some other LLM crosswalk, you can also use UMLS to crosswalk between different code concepts. It's the constitution of many smart people over a long period of time that have harmonized it. And so we're a big fan of leveraging, different LLM systems to adapt existing systems that are really good and do so in a way that's accessible. I have to look at a couple of different comments. Yeah, and so my main takeaway here is there's a difference between what's technically correct and clinically useful, and when in doubt, just go keep it simple is what we typically find. You can't go wrong is sort of what we see. And so I think it's important, as we're applying and building AI in these different systems, is we're doing so in a way that actually works with patients, providers, and researchers, and not in a way that is not just not practical for how healthcare is conducted today. I'm just going to read a couple of different things about. Yes. So, Ronald, to your point, I remember that vividly from my time doing machine learning on healthcare data in the 2017 to 2020 timeframe, where we spent a lot of time on interpretability, because it was just very unnerving for clinicians to review outputs for a predictive model for different outcomes when we didn't understand what they were doing. I think something that I took away, particularly from my work when I was at Amgen, was we always compared anything we were predicting against just using age and sex. And we would be like, is it better than just age and sex? And if so, you keep adding covariates to see what it gives you. And so that was often something that we would apply to be able to really see if adding the additional complexity was actually adding any benefit. Obviously, that's a very simple example, but I think today, we have maybe lost sight of that sometimes. And it makes it more challenging because now we're having to sort of, I would say, relearn a bunch of these things that we previously encountered. Oh yeah, I love playing the what's your favorite ICD code. I think mine is the difficulty with in-laws. Yeah, Ronald?
Just on that, actually, that reminded me, yeah, like a lot of the discussions like 10 years ago, the some of the barriers were a discomfort, like a sense of a lack of scientificness to, especially if you were just throwing in your own net and a lot of data into it. But when I was studying like comparative effectiveness research and health services as I moved into public health, I did hear more compelling arguments for like why you would prefer the explainable model. And it did have to do with the process and how that interacted within like policy development or community engagement or program management, things like that. As well as just the kind of pacing and nature of the research and the many unknowns it interacts with in public health work. But you described something I think that sounded more like that, but even maybe, I don't know if you or you know of others who have developed it, I'm really curious to hear. You mentioned that relying on the deterministic models was actually better, it sounded like for your QI work, for your ability to actually work on the EHR and clinical process. Did I understand that correctly?
Yeah, yeah, enabled us to fine tune, or I don't want to use the word fine tune because I don't mean it in the LLM way. It enabled us to um, more surgically modify parts of our process in a way that yielded better accuracy. So we were sort of the non-determinism was obfuscating other problems in the system.
And is that more like just the work of making the deterministic pipeline was an opportunity for QI or something else?
More like if your error bounds are like, let's say you're like, there's a big range in terms of your precision and your recall for predictive output. And maybe your precision ranges between 0.7 and 0.8, and maybe your recall ranges between 0.4 and 0.6. We were plateauing on recall until we started stamping out non-determinism because we couldn't even detect the fact that we had a recall issue. We said, okay, well, the recall's low, we're trying to find improvements in it, but we actually couldn't materially make improvements because some of the more nuanced recall issues were not even obvious until we stamped out some of the non-determinism. It's just more like
That,
an error, it's an error analysis problem.
yeah, that makes a lot of sense. And it's actually really similar to just the problem solving involved with building models of like health systems research, where you end up with a lot of multi-level problems. So figuring out what variables to include, what not, and making good DAGs to model that is its own long effort.
Yeah, I'm a big I started my career in hardware and systems engineering, so I like pulling
Mm,
tricks out from the hardware space because in hardware this stuff happens. You're like, I don't know what's going on, like this waveform is out of whack. We have some issue with grounding, like there's got some interference from other electrical signals. So you can't debug your system until you eliminate some of those other extraneous components. That's something that we're used to in the hardware space. I think that that's new. These are newer skills if you're building in software. I think some of these, though, are skills that we're familiar with from a researcher perspective. Like we think about confounding factors. Like we think about, okay, well, why is this outcome, this cohort of patients is doing better than this one. Why is that? Oh, well, it's highly predictive of medication adherence. Oh, okay, well, what's predicting medication adherence? Oh, their ability to access copay cards. This is stuff that we did at Amgen. Okay, well, if they're using copay cards, probably means that they're having issues with access to care, or the drug is priced at a point where it's not accessible, or the payer is not covering it on formulary, or something like that. And so it's often like, I think that's the cool part about working in healthcare data is that healthcare is just such a complex system. And so you end up having to find all these sort of like edges in the network to figure out where to identify. And I think that those skills can be applied in building these types of systems that work with healthcare because actually sort of this is philosophy I have is that AI powered systems remind me so much more of bioengineering than any other type of software I've built. Because in bioengineering, it's a non-deterministic system inherently. Like cells are non-deterministic. And so we have to figure out ways to like get them to, behave to produce proteins for therapeutic purposes. And similarly with LLM systems, we have to figure out how to QC them or get them to behave to produce reliable outputs.
Very cool. And do you speak on this or write on this or any of your team for particularly, I guess I'm trying to think how to mature my thinking and my colleagues' thinking so that we can have these discussions around like like strategically what tools and where are we investing without, essentially getting sucked into certain hype or going and spending a lot of time and energy in areas that if we had some of your maturity, we would actually be able to navigate and maybe weave pretty fine threads and say, hey, a little bit of this, a little bit of that.
Yeah, we have a healthcare AI Slack community that's free and open. So I'm happy to send an invite out to everybody on this call if you'd like to join it. There's a lot of folks building different healthcare AI software. I basically what I found is it's often these are conversations you end up having in these types of settings. This isn't the kind of stuff that you see on like LinkedIn or Twitter, although interestingly, when I do talk about this stuff on LinkedIn, it does pretty well. So it must be hitting on some kind of a nerve, which is, I think if you're a practitioner in this space, there are opportunities for all of us to share best practices. That's about it for my talk. We have a few minutes left for other questions. But I just sort of what my takeaway is like some things never change. We now have all of these new tools. We have all of this like data from the past and the present. But the main things that never change for anyone who's building this space is talking to the end user, understanding the clinical outcome and the impact. So thank you so much for having me. And yeah, I'm happy to take additional questions.
Thank you, Kerry. This was great. I learned so much from listening to you, and I appreciate your perspective. You kind of come at the LLM and evaluation challenge from a different space there's just so much there. I'm with Ronald. Like, if you have a book, let me read it. All right, questions for Kerry.
Oh, I can give you my email also.
Ian, you had an interesting comment here that I don't think we really dug into so much about the evaluation theory kind of bleeding between social sciences and AI systems
Oh,
evaluation.
oh, yeah. I mean, because we were talking about how, people use, Claude or ChatGPT to evaluate. But I was just thinking on the flip side, and the whole problem with the, benchmarks, which people like because they're easy to measure, not necessarily because they're useful. But I know at least, I believe that Google Research has a paper out, that basically arguing, I think correctly, that evaluating AI systems is really a social science problem. We should treat it like we do when we're trying to either understand people or understand systems, or I'm thinking in terms of what Ronald was saying, evaluation theory is kind of might be an ideal construct for evaluating at least from the point of view of how well does an AI system work for your organization or a task organization.
Yeah, that's cool. I like that. I think that's so interesting. I think that makes sense for AI systems that are used in a conversational manner or a more like agents. If you think about working with an AI as a partner, I think that makes a lot of sense to do that. When I think about AI that's used as a tool where you're not interacting with it as like another human, the other analogies I tend to draw on is the medical device space. Because I think of other spaces where we're measuring, especially like in vitro diagnostics, where we're using biology or chemistry to measure an output, and we have to get it through like a very rigorous process to get it approved. And so we think about like evaluation of those kinds of like stochastic systems we always boil it up to like, does it address the user's needs? And that's like how we get it approved through the FDA. And so that's like the analogy you draw there. I think for the chat-based systems where you're like, how well is ChatGPT interacting with someone as a human? I think that makes a lot of sense. Yeah, that's cool. Tina?
Hi. Yeah, I wanted to just confirm your statement about how a lot of the data is incentivized legally or monetarily, especially because I work in immunization. So I'm definitely on the legal compliance side of getting my providers to submit our required data for immunization, but it's very difficult when some of the data is not required, but then we get initiatives to really look into like that type of information when it's not required. So yeah, and especially with the different states and the various immunization schedules that has become different for each state. It's I think the unstructured, like by nature our federated system is unstructured because we have different states, but there is definitely a federal desire to make it all structured. So I think some of the concepts you talked about would be interesting to apply, especially to immunization.
Yeah, I think my philosophy there is there's opportunities for taking the data, being permissive in how the data is shared, and then being able to adapt it to structured forms downstream, and or making it exceptionally easy and user friendly to share the information in a semi-structured way. I think the reality of what I see in healthcare is that it's often just easier for clinicians to just fax something or send a PDF. And so therefore, if we want standardization, then we need to build systems that can do adaptation for those folks, which I think is very, yeah, obviously that's a space that we're really focused on, and we feel very passionately about. And I think it ultimately is, I think that could be a good opportunity. So I know we're at the top of the hour. So thank you so much, everybody, for having me. I really appreciate it.
Yeah, thanks so much, Kerry. This was great, and appreciate your time and expertise here. And folks, we had a lot of links and a lot of articles and everything shared. Our trusty co-pilot Allie will round them all up and get those out to you in the meeting summary, and we'll include Kerry's stuff. Kerry just send things over, and we'll make sure those get into the notes as well.
Awesome.
Thanks so much, everyone. We'll see you in 2 weeks. Take care.
Thank you.